I'm just remembering what I read. I want to make sure that you guys are prepared. Okay, I would be aware of this blepharitis. Remember, that's all the stuff on the eyebrows. Entropion is the inward in. Think of an in, the eyelashes going in. You have to have surgery. Ectropion, the eyelashes are the turning out of the lid. Hordeolum, those can be internal or external. And so that's a sty. And the chalazion, inflammation of the sebaceous gland and eye. Those are typically on both sides, right? Usually bilateral. Common approaches to care for eyelid disorders. What are our common approaches? We're going to go possibly we'll see the doctor, but they may have to go to surgery. What's one of the things you can always do that doesn't harm anything? A warm, moist compress, right? Especially for those styes. And also for infection-wise, you would, if you're anything with a gut drainage from the eye, you can do a nice warm compress, and you can bring it out, but you do not put that infected part against them again. Put a clean part, and then rinse and use multiple washcloths. It's okay to wash a load of all the washcloths you have, or half of them. You can even do the same thing with the towel. Ophthalmic ointment, like you said, you're going to lower, and then you're going to put it in and all the way across with an ointment on the bottom. This is hard for patients to do themselves. I mean, how can you see? You've already got macular degeneration. You already have problems with your eyesight. How are you going to see to do this? That's that sense of feel. It's pretty tough because you can't squeeze out, a half inch of ointment, and then here, how are you going to get that up here without touching everything? And any kind of thing we're putting in the eye, you cannot let the container touch the eye. So it's difficult. My mom said, this is part of the hardest thing I have to do is put in these things all by myself, without anybody there. But she's got it down to a science now, but you keep them encouraged. Make sure your hands are washed, always hands washed, right? Then now, and make sure don't touch the squeak and do the best they can. That's all we can encourage them. Blepharitis, you will see again. There's a nice picture of it. There's our picture of entropion versus ectropion. You can see where both of them are a problem. They'll need surgery to fix. After an eye surgery, let's just say they had trauma, or, and you've got stitches, or they had to make repairs. What kind of thing do we want to see with that? As far as how can I put this? What would make you nervous if after a surgery, this is almost any surgery, about an incision? Do we want it to be warm and healing right afterwards and a little bit reddened? Does it first happen? I mean, I'm talking within the first 24 hours. We want it to have a little color and be warm, and because that's showing us that there's circulation. Anybody comes back from surgery and everything, they're going to be cold because the OR is cold, right? But if anybody comes back from surgery and that incision is not warm, or we don't see blood flow to it. So that even goes with eye surgeries and head traumas. You need to make sure there should be a little swelling, a little redness.
Will they have a patch over it? Type
different things they may put a patch over.
With that initial dressing, we won't remove.
Correct. Who removes the first initial dressing? Surgeons. Doctors always remove that unless they specifically put it in a note. Okay? So, depending on what the treatment was, like I said, I've had corneal ulcers since, but when I first had them in nursing school, the treatment was, man, I had eye patches for 2 weeks. It was just really grand. But I mean, and it's an irritation to have that patch on there too. Because the eye wants to open, the eye wants to blink, and then it can't. And so that's the reason why they don't do patches as long. They'll do it for a shorter time period because they found that was damaging to the muscles of the eye to do it that long. Okay, here we go with the bilateral. See the glands were infected. We made it through the dry eye syndrome, right? make sure that they've got artificial tears. A hemorrhage, when we see a big hemorrhage, those are usually no pain. Usually goes away in 14 days, and yesterday I saw one in one of the instructors' like, just went over that. They had no idea why. What's this? Nasty pink eye. It's quite infectious, right? Okay, trachoma, the bilateral scarring, caused by chlamydia. Corneal disorders, we talked about all those. All right, any questions on corneal disorders? Corneal transplant? What do we have to make sure that transplant patient does after surgery? We don't want them to bend, we don't really want them to cough, sneeze, blow their nose, anything that would increase pressure, right? And we talked about this, and yes, they are supposed to be cancer-free at death. You will see that again. I believe that was her question. Elevate the head 30 degrees. On the possible eye donors, you can do eye packs. We no longer put antibiotic eye drops in. If you do make your license, you know, they ask you when you go to get your license if you are a donor or not, and that's your option to put it on there. But an interesting fact is, you go back to get your license and you say, I no longer want to be on the list. Doesn't matter. The state can't take you off the list. You have to contact Missouri Transplant to get your name off the list if you no longer want to be there. So in case you change your mind, in case you see the vultures at work, there's times had to deal with a lot of death and dying and had to deal with the transplant services. Sometimes they will come in and they're nurses, and and I've seen them, I mean, I had like a 19-year-old that was brain dead that we had to, you know, get the organs and things. But emotionally, those families weren't ready yet. And so sometimes they can really deter them, and it's very, very emotional times for everybody. So I've seen that deter people from wanting to do, you know, to donate, and with reasonable cause. I mean, I'm like, yeah, I get it. But I didn't know that if you go to the, to get your license, if you change it there, it's not gonna matter. So just keep that in mind if somebody changes their mind. Talked about cataracts, clouding, you don't have pain. That's the lens, that's why I want the lens transplanted. Dark glasses required. We're gonna do their eye drops, and it's usually unpatched now. And we're gonna reduce the intraoptic pressure by what? What are we gonna do? We're not gonna let them sneeze, we're not gonna let them cough, we're not gonna let them anything. No sharp sudden pain in the eye afterwards. And here we are, glaucoma. This is that eye pressure. Cupping and atrophy of the optic disc. That optic disc isn't able to work well anymore. They may have symptoms, but not usually until it's too late do they have symptoms. Their symptoms may be a mild headache, or maybe some brow pain. If their headaches to the point of nausea and vomiting, or the colored halos, then we are to a point of problems. Okay? I can't just find those. But the colored halos are a big thing. And it's not stars, it's halos. Sudden blurred vision with decreased light perception. The other thing you're going to notice with glaucoma is it's going to come from the sides. They're going to lose their vision, their peripheral vision, until it comes in the front. Okay, I'm going to keep that. The primary type is the open angle glaucoma, and that's more of a gradual because of all this increased ocular pressure. And the angle closure glaucoma is a medical emergency. They will lose their eyesight within hours. It will cause blindness. got the different kinds of testing for it. Sonometry, they're gonna be checking the pressures. They will be able to look at the back of the vessels to see, and they'll look at the optic nerve. Has anybody ever done a test where they're looking at your optic nerve? And they have this big bright light, and then they have, it'll be on a screen, and you can see your entire eyeball. When they're looking, and you can see, when they're looking in your eye, and all of a sudden, you see all your blood vessels. You guys notice that in an eye exam? Pretty fun, isn't it? Okay, we talked a little bit about drug therapy, how eye drops work. If your patient has more than one set of eye drops, what do we need to make sure we do? Give it at least 5 minutes between types of eye drops, and we need to make sure we teach that to our patients. Number 1, wash their hands. Number 2, you're not going to touch any of the tip, okay? And number 3, make sure you give time between eye drops. We're going to monitor for their side effects. What happens if we give them an eye drop? Let's give them Timoptic or Timolol, ends in OL, right? It's going to decrease their eye pressure. What else do you think it'll decrease? It's because it can go systemic too. So even when you're given eye drops, you got to make sure if you add those to it, that it's not a problem with their other meds or cause any complications. Timely dosing, especially any kind of blood pressure medications, any kind of eye medications, antibiotics, all those things, or water pills. We want them on a timely basis, right? Okay. Other eye disorders, macular degeneration. Okay, has anybody heard of this? Okay, this is definitely an old people's disease. Macular degeneration is age-related. It's deterior of the macula, which controls that central vision. So a lot of times they're not even going to have central eyesight. They'll have blurring and visual distortion, and it cannot be corrected. Okay, and there's types. There's a dry, and there's a wet. So it depends on how much fluid is in the eye, and that causes big trouble. Refractive errors. What's myopia? You know this one. Got it? Nearsighted. See things up close, can't see things far away. What's hyperopia? Farsighted, can't see things close up, can see things far away. We already talked about presbyopia. What's that one? I can't hear you.
Age-related.
Age-related, so over 40, but what does it do? You see them hold things out. You'll see me hold things out. We're over age 40 typically, because I can no longer read close. I have to get it out here because the eyeball's not as elastic as it was, and so it can't compensate as well. Accommodation doesn't happen as well. Presbyopia, and what's in astigmatism? I'm sorry. Eye curves. Yeah. So there's different. It's not going to be a nice little smooth thing, and to treat that for the light to go in at the different things, it's kind of like looking at a prism. Have you ever looked in a glass prism? You've seen pretty things, but it changes. That's exactly what astigmatisms do. When you're trying, they have to correct that so that you can see the right thing. Okay. Trauma, hyphema, contusion, foreign bodies, lacerations, penetrating injuries. Any questions on those? What are we going to do if we have a foreign body? Are we going to remove it ourselves from the eye? Not at all. What are we going to do? We're going to make our patient as comfortable as we can, but you're going to get them ready. Lacerations and cuts. Is it bad to cut the eyeball open? Yeah. It is. The worst thing is when stuff comes out the eyeball and protrudes, that's when they'll probably lose their eye. Because if we can keep it all intact, you may be able to save a portion of it. But if they actually get it sliced with an axe or something, then the stuff that's coming out, if if there's stuff coming out, they won't be able to put it back in and replace pressure. They usually have to lose the eye. We talked about a vitreous hemorrhage, hereditary ocular melanoma. So there is eye cancer, okay? And that's, you're gonna notice changes in vision, changes in problem. Eyes are not something to mess with, especially there's the glaucoma, and you know, if they end up with that, what kind did I say? There was a specific kind of glaucoma that the pressures went up high and they're not able to bring them down, and it's gonna compress on that nerve. Which one? Closed angle. There you go. Reduced vision. So if somebody has reduced vision, you have to communicate using adaptive items. And that's ears or eyes, right? So I definitely have to have them. I'm gonna make sure they're familiar with their area that they're staying. You don't move the furniture on them, things like that, if somebody doesn't have their glasses. Somebody with eyesight like mine, I keep another set of glasses. I don't ever throw away the old pair. You keep the most recent prescription with you, or around you at least. Let's put it this way. That's how I got my badge to work twice. I was here, I had my contacts in, went to go to my friends to spend the night. Got so many bags of these books, because I even get more books than you guys get. I'm so lucky. And I always carry my glasses with me, and I have too small of a purse because my back injuries, I try not to carry too many heavy things, or at least on one side. So I didn't have my glasses with me. And I had to take my contacts out. There's no way I could see if I had my contacts out. So back up here, security, please let me in, come get my glasses, because I always have them with me. Ambulate with care, of course. You're going to assist them promote self-care and independence, and you're going to do your best to support them for a loss of sight. Okay, case study. Why did it only affect his left eye? Why did the cataracts have to affect both eyes? No, it can be just one eye for certain. Scheduled for cataract surgery. What do you think? Are we going to tell them D to avoid wearing glasses, dark glasses? No, they need them. Is he going to see the best immediately? A, no, it takes 4 to 6 weeks. So which one is it? B or C? C. C? What's the computer say? C. Different types of eye drops for at least 2 to 4 weeks, yes. And that he'll no longer need to wear eyeglasses for reading. That is a possibility, but it depends on how the lens takes and how they do. I know my dad, after his cataract surgery, didn't have to wear glasses anymore. That was pretty cool. He'd worn glasses his whole life. After the patient's cataract surgery, brought to the recovery area. And we're going to give eye drops and other medications. Which order for the patient should the nurse question? What's that? Warfarin, Coumadin. Do we want them to bleed out? I don't think so. After recovery, which statement by the patient indicates a need for further teaching? What's your answer?
B.
B. Aspirin will help decrease comfort. Why do we want to give aspirin? For bleeding. All right. This reminds me of a question that I saw, and it's different in the previous book than it is in this book. This book says that they haven't found a reason why people will develop cataracts, and previous books say that to prevent, you can wear sunglasses. So you might not find it in this text, but you might want to know that sunglasses will help prevent, okay? Remember, tests can be given over lecture as well as book content. So, and that was part of the quiz stuff when we went over the quiz. We had Jen take the quiz. She goes, well, I always cover that in lecture. Maybe it's not in the book anymore, but no, it's not in this book. It's not back till edition 7. I'm like, how am I supposed to know what edition 7 says? We're in edition 10. So just remember, questions can be over content, so I'm making sure you're getting all the content. Okay. Nurse understands that which is a post-op outcome is undergone surgery. What's our answer supposed to be? Had their cataract taken off. What's the answer? B. All right, mild itching and bloodshot appearance. We don't want pain. They're not supposed to have a lot of pain or nausea and vomiting. We don't want nausea and vomiting because we don't want all that pressure going against the new cornea, okay? Their change accompanied by tearing and redness, change in the visual acuity. That should not change, and we don't want any yellow drainage. What's the priority for teaching-wise? Corneal transplant. We're not covering the eye anymore, right? What's your answer? C? No straining. We want them to watch for signs of an infection, but that's probably not going to be within that very first part. Okay, which patient is at greatest risk of developing primary angle closure glaucoma? It's usually over age 60 for glaucoma, and it happens more in African American and Hispanic over the age of 50. So our answer should be D. Does that match? What did they give you? C?
A.
What?
So it's more common in women and Asians.
Okay, look it up with me, guys.
The source.
It says the African Americans and Hispanics have a greater tendency for developing primary glaucoma.
It's you, huh?
So I don't know why it wouldn't have D as the answer, 'cause it says that too.
We didn't talk about the pressures. What's the normal pressure amount of intraocular pressure should be? Should be 20 to 30. I'm sorry, 10 to 20, 10 to 20, 22 to 32, and in the 30s for certain is glaucoma. It's in here. Did anybody find it in your book? Promise it's in here.
On page 942,
942.
bottom, says, bottom right.
Yep, African Americans, Hispanics, Latino over 40, and Indian individual over 60, who have a family history of glaucoma, and adults who have high eye pressure, corneal thinness, and abnormality of the optic nerve. Doesn't say anything about Asian, right?
Well, the rationale for this, they
Uh-huh.
sourced it from the Glaucoma Foundation.
Okay.
That was in 2014.
according to our book. Okay. I'm gonna make this little note here. So the Glaucoma Society is saying it's the Asian female. Our book says it would either be the Hispanic or African American, and they're saying over the age of 40. So if I had to guess between the two, I would take the older one, right? The 64-year-old, that's why I gave my answer. I do not believe this is a test question, but I will just double investigate. Okay. So we'll go back. All right, so this gives us almost an hour to have a fun. Go ahead and get a break, okay? And then we're gonna do some of the other things that Jim wanted us to do. Unless you have questions. If you have questions, I will always be ready for questions, but.
Question on ear tubes.
Mhm.
So how often do they get changed?
Tubes, if they're putting tubes in, no, they don't get changed, they will fall out.
They'll fall out.
Eventually, usually a year or two. Usually a year or two, and those will come out. And then that's why I said after that, if they need another set, they'll put a T-tube in, because really there's all this scar tissue, they've gotta have something to hold it.
I slept.
So put something in that has, and then that's supposed to be surgically removed. My son, he only had to have one removed, but I was already gone. But active little boys.
Yeah.
I probably wouldn't even bother going off of the glaucoma foundation because it's not even, it doesn't even pull up anymore.
Okay,
It was
All right.
active in 2014, so I'd probably just go buy this one.
go by the book.
Yeah.
Thank you.
You're welcome.
Because I was like, wait a minute, I just read that.
Yeah.
I know I'm old and forgetful, but hopefully some of it